Hi, my name is Daniela Kadian-Dodov, and I'm a vascular medicine specialist at Mount Sinai Medical Center in New York. And today I'm going to be discussing vascular findings in patients with cervical artery dissection in the absence or presence of FMD. It's an absolute honor for me to be here with you today to share our findings. To begin the discussion, I just wanted to take some time to define what is arterial dissection. And I have some images to help me do that. In the top left, you see a cartoon of an artery and its 3 layers that make up the artery wall. In general, arteries should be straight, smooth pipes that provide blood to whatever is being supplied by that artery. And these 3 layers in the wall help the artery to do that job and maintain its strength and integrity over time. To the right, you can see an angiogram showing a carotid artery that initially starts off nice, straight, and smooth, and then becomes very irregular, and then ultimately returns to a smooth artery. This area of irregularity is an arterial dissection, and what's actually happening is shown in this cartoon here. There's a tear into the wall of the artery and a separation of the wall layers. What can happen is a blood clot can actually form in between the layers of the wall to ultimately block off blood flow. And the way the blood flow is blocked off is twofold. So if you come to the lower cartoon here, you can see there's a blood clot between the tear and the wall of the artery. What can happen is a piece of that blood clot can actually break off and travel to whatever's being supplied. In the case of a cervical artery dissection, that would be the brain, to cause a stroke or stroke-like symptoms. Alternatively, the blood clot can accumulate and actually block off flow completely. And this is why most of our management for cervical artery dissection is focused on reducing the stress on the artery walls in any way that we can with blood pressure control and lifestyle modifications, and then some level of blood thinning, whether it be an aspirin or a full dose blood thinner. Now, like FMD, cervical artery dissection is an imaging diagnosis, and so we know it when we see it, and it has many different appearances on imaging, and I've shown some examples here for you. So what we're looking at, starting on the left-hand side, is the vertebral arteries, which is these light gray lines going through the vertebral bodies on a CAT scan. And the arrow is showing you that the left vertebral artery is split. It has this dark line separating 2 channels where there should be 1. The right vertebral artery is normal for comparison. So this flap is called an intimal flap, and then we've got a double lumen, again, where there should be 1. If we cut this artery in half and looked at it in cross-section, you would see this. So instead of having a complete round circle, we've got a split circle with that gray line and 2 channels of blood flow where there should be 1. This angiogram is showing you a pseudoaneurysm or a false aneurysm. So the carotid artery is dissected and there's flow in between the wall layers with an area that looks like bulging. And so this is not a real aneurysm, it's a false aneurysm, which is why we call it a pseudoaneurysm that is formed in the area of dissection. Over time, as dissections heal, the artery can undergo some remodeling and become changed from where it started. And this is showing you aneurysmal degeneration. So the artery is now kind of irregular in appearance. It's bulging where it should be kind of a smooth straight line. And this appearance is most often mistaken for multifocal FMD or string of beads. Importantly, it looks different because the string of beads, which you may have seen in other talks today, is usually kind of a tight irregularity causing beading, whereas this is more, again, of a bulging or aneurysm formation with irregularity. This is why the international consensus for FMD has said that we can't call a dissection, and we can't call FMD in an artery that has had a dissection, because as it remodels over time, it can have this appearance that can sometimes be mistaken for FMD, but actually isn't. Now, if that blood clot accumulates to completely block off blood flow, we may see this, which is a flame-tipped occlusion. So the white in this image is actually the artery lumen, and the carotid artery should be continuing all the way up the neck to the brain, and in this case, it is actually stopped completely. If it doesn't completely block off, you may have the appearance of this lower image, which is long, smooth narrowing with a return to normal artery. So this is blood clot compressing that normal lumen of the artery, causing the long, smooth narrowing. And again, all of these are cervical artery dissection. Most of our understanding about the risk factors and demographics for these patients comes from the cervical artery dissection and ischemic stroke patients group, which is a consortium of over 20 centers across 9 countries, mostly in Europe, but also including Argentina. And this started initially to try and identify genetic polymorphisms that might increase the risk of cervical artery dissection. Patients were recruited between 2004 and 2009. They got over 1,000 cervical artery dissection patients, similar ischemic stroke patients with more traditional stroke, and then 2,000 healthy controls that were all matched by geographic region. In terms of the criteria for enrollment, the cervical artery dissection patients had to have a dissection that was defined by imaging characteristics, as I showed you. And then they tried to exclude patients with any possible underlying cause of dissection. So namely, a procedure in the hospital that led to a dissection, or some kind of inherited connective tissue disease that was known to be associated with arterial dissection, like Loeys-Dietz or vascular Ehlers-Danlos. The ischemic stroke patients had to have a confirmed ischemic stroke that was due to atherosclerosis, meaning cholesterol plaque, and not due to something else like autoimmune disease, vasospasm, or an embolism from the heart. And then the healthy subjects had to have no history of vascular disease. Now, here's some examples of inherited connective tissue diseases that are known to be associated with cervical artery dissection. On the top, you can see Loeys-Dietz syndrome, which is characterized by extreme arterial tortuosity or curviness. These are neck arteries, and what you can see is that they're doubling back on themselves. They've got multiple loops and coils, and are just very elongated compared to what a normal artery would look like. The uvula for these patients can often be split or bifid, and they may have widely spaced eyes as well. Vascular Ehlers-Danlos or Ehlers-Danlos type 4 is associated with arterial dissection, aneurysm, or rupture, but also intestinal or uterine rupture. And these patients can have some characteristic findings on physical exam as well. Widely spaced eyes, a thin nose bridge, and then a thin lip as well, and visible veins beneath the skin and translucent skin. So each of the patients that were enrolled had a clinical questionnaire that they completed, looking at past medical history and family history. They looked at clinical signs and symptoms, their imaging exams, and then any information on therapy and outcomes. Importantly, these patients were not systematically imaged below the neck. So that's a major limitation of the data from this and is a main driver for the study that I'm going to present towards the end from our center. In terms of what we learned from the CADIS consortium, basically, overall cervical artery dissection seems to be slightly more common in men, but when women experience cervical artery dissection, they present about 5 years younger. So you can see the age distribution in this image on the right and the frequency on the y-axis, and the light gray represents women. The peak comes about 5 years earlier than it does for men. And other than hypertension, this is not something that's associated with traditional cardiovascular risk factors like high cholesterol, diabetes, or obesity. This seems to be a completely separate entity. And there's some data to support that perhaps there's an underlying arterial abnormality that might predispose patients to this. I'll show you some data from histopathology. The fact that it's been associated with other arteriopathies like FMD suggests that it may by itself have a predisposition or be an arteriopathy alone. There's some genetic data and then imaging findings as well. So in terms of intrinsic weakness or predisposition, there is imaging data showing that arterial tortuosity or S curves, as you can see on this carotid on the left and loops is much more common in patients that have cervical artery dissection as compared to healthy controls. So in one study, 65% of patients with a cervical artery dissection had these tortuosity findings as compared to about 18.5% of controls. And this is in keeping with what we've seen in our FMD patients. So arterial tortuosity is much more common in patients with FMD as compared to sex and age-matched control. And Dr. Olin and Dr. Sethi presented that data a number of years ago, and it's well described now. Additionally, there's some pathologic findings on temporal artery biopsies that suggest that the arteries overall are not normal in patients with cervical artery dissection. Temporal arteries run across the forehead area and they're easily biopsied. So this study looked at patients with cervical artery dissection, and the controls were motor vehicle accident patients. And what they found when they looked under the microscope is that these superficial temporal arteries actually had blood flowing in between the wall layers, like micro dissections, which you can see here. And in the larger view, this H is blood flowing between the adventitia and the media. They also had a capillary formation, which was just abnormal growth of capillaries in the walls and speaks to just a disorganization of the makeup of the architecture of the artery walls in patients with cervical artery dissection compared to controls. Now, we know that dissection is a manifestation of FMD, as is a number of other findings. So what you can see on the far left is the string of beads, and again, those tight beads as compared to that aneurysmal degeneration from dissection that I showed you earlier. Just want you to keep that in mind. A single area of stenosis or focal FMD, aneurysm formation, and extreme tortuosity have all been described in patients with FMD. Importantly, tortuosity, aneurysm, and dissection can be caused by many other things, so we can only attribute these findings to FMD when we see the typical multifocal or string of beads FMD or focal FMD in an artery without dissection. And again, dissection and aneurysm are common in patients with FMD. We learned from the US Registry for FMD that at the time of FMD diagnosis, nearly 42% of patients had an aneurysm or dissection on imaging. And far and away, the carotid and vertebral arteries were the most common location for dissection that was detected. So when we look at the overlap between cervical artery dissection and FMD in the literature, from the US Registry, overall, out of 921 patients at the time of diagnosis, 19% had a cervical artery dissection, which was the most common location of dissection experienced by patients with FMD. And about 37% of these were multiple cervical artery dissections, so not just one. If you look at cervical artery dissection patients in the literature, FMD is reported in about 20% when patients are screened. But importantly, those studies did not image patients below the neck. So we really have no idea of the coprevalence of these two entities in those earlier studies. From the CADIS data, we know that about 15% of patients have more than one cervical artery dissection. And when they drilled down, the patients with multiple cervical arteries that dissected were 4 times more likely to have FMD in the head and the neck. Now, more recently, the Arcadia registry, which included 469 patients, did systematically image head to pelvis, and they found that about 14% had cervical artery dissection, which was associated with male sex and more multiple vascular beds involved with FMD. So a smaller study from the larger Arcadia registry out of Poland tried to identify the coprevalence of FMD and cervical artery dissection, or how frequently these two things run together. And so they enrolled patients with suspected or diagnosed FMD, cervical artery dissection alone, or SCAD, and all those patients underwent head to pelvis imaging. Ultimately, they ended up with 43 patients with a cervical artery dissection and 152 FMD patients. And the overlap for cervical artery dissection and FMD was about almost 40% of patients with cervical artery dissection ended up having FMD in this study. Now, this was a really small study. I don't think it's generalizable across the board, but it does suggest that when you pan image patients, perhaps the overlap is higher than we've originally suspected. Now, one thing we don't know is whether or not the presentation, risk factors, natural history, or vascular phenotype of patients with FMD and cervical artery dissection differs from patients with cervical artery dissection alone. In today's world, we treat these patients one and the same, and general guidelines apply. Now, the genetic basis for the clinical overlap of FMD and cervical artery dissection and now SCAD has been established, and the first variant that was identified was in the factor 1 gene, which is a member of the phosphatase and actin regulator family of proteins that plays a role in actin and contractile filament organization. And this top variant that was identified is associated with an increased risk of cervical artery dissection, FMD, migraines, and SCAD. And interestingly, it's associated with a reduced risk of myocardial infarction or heart attack and coronary artery disease due to cholesterol plaque. So we're starting to see that there is some genetic basis for the overlap that we've been observing. In terms of other vascular findings that we can glean from the available data today, we know that FMD is associated with a higher rate of cerebral aneurysm, about 12.9%. From the US Registry for FMD, and this is compared to the general population, which is about 5% in the literature. There's only one study that I was able to find that looked at rates of cerebral aneurysm in patients with cervical artery dissection. It's from the 90s, and it reports 5.5% of patients with cervical artery dissection had an aneurysm. And again, there were no prior studies aside from the more recent Arcadia registry studies that systematically image patients with cervical artery dissection below the neck. So that brings me to our research objective, which is to define the clinical phenotype or presentation of patients that have been referred to our clinic at Mount Sinai between 2016 and 2019 with a possible diagnosis of FMD. We separated these patients into two buckets based on their results, either cervical artery dissection alone or those that had cervical artery dissection and FMD. Since 2014, we've been getting head to pelvis imaging for all our FMD patients, and we started doing the same thing in 2016 for patients with cervical artery dissection that were referred to our center because of the overlap that we've been seeing over time. And so these are the demographics and data from our patients between 2016 and 2019. We had 87 patients with FMD and cervical artery dissection that were newly evaluated and 59 cervical artery dissection patients. The age at cervical artery diagnosis is lower or younger in patients with cervical artery dissection alone as compared to those that had FMD. Additionally, there was a higher rate of women in the FMD cohort as compared to those with cervical artery dissection alone. There was no difference in race, hypertension, active or former smoking or drug use, which included marijuana, cocaine, and amphetamines for this group. There was a higher rate of significant family history in first and second degree relatives for FMD, aneurysm, dissection, or heart attack, stroke, or sudden death at a young age in patients with FMD and cervical artery dissection as compared to those with cervical artery dissection alone. Although overall, the rate was pretty high for both groups. Now, looking at presentation and distribution of disease, in terms of the location of cervical artery dissection, there was a higher rate of vertebral artery involvement in patients with cervical artery dissection alone as compared to those with FMD. There was also a higher rate of multiple cervical artery dissections that just achieved statistical significance in patients with cervical artery dissection alone as compared to those with FMD. A higher rate of FMD patients were asymptomatic in terms of the detection of the cervical artery dissection, which is not totally surprising since those patients at FMD diagnosis are undergoing head to pelvis imaging. Whereas for a cervical artery dissection, you may not have that diagnosis unless you present with symptoms and then undergo imaging. So there was a high rate of pain and stroke and organ ischemia, stroke-like symptoms in patients with cervical artery dissection alone. In terms of rate of recurrence, the rate of recurrence was much higher in patients with cervical artery dissection alone as compared to FMD, 22% compared to 8.1% in patients with FMD and cervical artery dissection. And the majority of these occurred in a new artery rather than the same artery. In terms of the time from the original cervical artery dissection event, for cervical artery dissection patients alone, this happened much sooner at about 27 months compared to 49.9 months in patients with FMD and cervical artery dissection. And the majority of these patients had symptoms. So very few were asymptomatic and detected on follow-up imaging. The majority presented with pain or stroke or stroke-like symptoms. In terms of other findings, there was a high rate of aneurysm in patients with FMD or without FMD in those that had cervical artery dissection. And this was not statistically significant between the two groups, so no difference really. 48.3% in patients with FMD and cervical artery dissection compared to 40.7% in patients with cervical artery dissection alone. There was a difference in the distribution of the findings. So there was a higher rate of cerebral aneurysm in patients with FMD compared to those with cervical artery dissection alone. On the other hand, there was a higher rate of aortic aneurysm, particularly thoracic aortic aneurysm, in patients with cervical artery dissection as compared to those with FMD. Other areas of dissection were 18.4% in patients with FMD and cervical artery dissection as compared to 27.1% in patients with cervical artery dissection alone. This was not statistically significant between the groups, and there was no difference in the locations between the groups. There was also no significant difference between cervical artery dissection related pseudoaneurysm between the groups. So in conclusion, patients with cervical artery dissection alone were younger, more often men, and more frequently experienced vertebral artery dissection compared to those with cervical artery dissection in FMD. And again, it's not totally surprising that we're seeing more women in the FMD group, since FMD is a condition that affects women more than men. Although men that have FMD tend to experience dissection or aneurysm more frequently. Patients with cervical artery dissection alone have a high rate of aneurysm and or dissection below the neck. When we broke it down, it was about 51.8% of these patients had an aneurysm and or dissection. And this supports that cervical artery dissection by itself is a generalized arteriopathy, and we should be screening these patients with head to pelvis imaging at cervical artery dissection diagnosis, just as we do for our FMD patients and our SCAD patients at diagnosis. Finally, patients with cervical artery dissection alone experienced recurrent cervical artery dissection more frequently than patients with FMD, 22% versus 8%, and the mean time from recurrence was shorter for patients with cervical artery dissection alone as compared to those that had FMD. And this is somewhat different than what's been historically reported for cervical artery dissection patients. Typically, the literature reports about 1% per year rate of recurrence for cervical artery dissection out to 10 years of follow-up. It's possible that our data is demonstrating some selection bias because most of these patients were symptomatic and they were returning for follow-up on a regular basis as compared to the more historical data. But there may be some differences between how these patients behave, and that needs to be further investigated with larger patient groups. And with that, I thank you. Again, it was a real pleasure to be here with you today and to share our most recent data from Mount Sinai. Thank you very much.